Hello, everybody. Thank you for being here and welcome to our PBRN research seminar series. Today's seminar is titled Advancing QI Across McGill, Building on Resident QI Initiatives. Moderating today's session is Dr. Keith Todd. So I'm just going to say a few words about Keith. After completing his graduate studies and research fellowship, Dr. Todd turned to medical school, where he completed his medical degree and family medicine residency at McGill. Since graduating, he has been a staff physician at the Herzl Clinic and the Jewish General Hospital, where he practices family and hospital medicine. He's been involved in teaching residents and quality improvement methods for the past 8 years. And in 2025, he became the Director of Quality Improvement for the Department of Family Medicine. So, Keith, the floor is yours.
Thanks, Michelle. Okay, so today, the goal of this session is to put the spotlight on some of the work that goes on annually with our resident projects around quality improvement, and these projects vary widely across our various teaching sites, and they're really guided by local problems and concerns that are faced by the staff, clinicians, and the residents in those units. But one thing that I think would be really interesting to sort of think about is how these projects could be adapted and moved more broadly across our network so that they have some lasting impact. Because one of the things that many of us can sort of attest to is that we put a lot of work into some of these projects, and they're excellent projects. And then as the residents move on with their careers, the projects often kind of fizzle and die. And so this is a chance for us to sort of see some of the work that's been done and hopefully have some discussions around how some of these things could be potentially adapted across our network. So we're going to start. I'm going to stop talking, and we're going to ask some of our residents, Glen, Meng, Bao-Lam, Pham, and Antoine Picard, to talk to us about Don't Fear the Smear, Improving Training Comfort with PAP Tests. All right, guys, the floor is yours.
I'll just share the screen.
Can you see the screen?
Yeah.
Yes.
Okay, so thank you for the introduction. So today we're going to present the project that we did, which is called Don't Fear the Smear, Improving Trainee Comfort with PAP Test. So the three of us did this project, and we were supervised by Dr. Kovacina, a staff at St. Mary's as well. We have no conflict of interest to declare. So basically, the background and why we chose this project is, first of all, cervical cancer is an important cause of cancer in Canada. There's an incidence of 8 per 100,000 women in 2020. And in 2017, cervical screening participation for women aged 21 to 69 years, corrected also for previous hysterectomy in Canada, was 76.6%. So we found that there was still some improvement to be made in terms of access to PAP tests. And also the other thing that we noticed is at the beginning of residency of our 1 year last year, we noticed that a lot of our co-residents and a lot of trainees were not necessarily comfortable with PAP test screening because there is some training in medical school, but we don't do it repetitively, so it can be a bit intimidating at first to do them. So the level of comfort could also be addressed with our project. So there's a lack of exposure because of limited resources and time to train us, I think. So we came up with our clinical question. So in medical residents, does participation in a structured PAP test screening clinic improve confidence compared to residents with no such training? So we did a literature search that included a PubMed search with the following mesh terms, so internship in residency or schools medical and cervical cancer screening or Pap test, and we found 67 studies from this search. There were some exclusion criteria like outdated articles and English articles that were not in English as well. And we wanted articles that only focused on Pap test screenings, and also on confidence or trainee outcomes. So based on these results, there were 6 articles that matched our literature search. So I'll just briefly present 2 of them. So this is just the Prisma diagram that shows kind of our studies and how we came up with, at the end, 6 studies that we looked at. So those are 2 of the studies that were relevant for our presentation. So there was one article, the association between the number of Pap smears performed and self-reported confidence in an internal medicine residency. So this study, the conclusion, it highlights really the relationship between increased exposure to Pap test and confidence level. So it also kind of increased our confidence that this project would be useful. And also the second one was even more relevant, I think, and it's a structured women's preventive health clinic for residents, a quality improvement project designed to meet training needs and improve cervical cancer screening rates. So this study was done also for internal medicine residents, and it also provided a framework for implementation of a women's clinic and reinforces also the increase in confidence in trainees that did participate in such an intervention.
So our aim of the QI project was to increase the trainee comfort rate by 30% in family medicine residents. So how it works at St. Mary's, we have these procedures months and that are implemented throughout our training. So we decided to use those months to implement these 2 half days of Pap tests during these procedural skills month. And this ran from about February until May of this year. What we did was that we used a Likert scale to assess trainee comfort level. So there were about 5 questions. We'll show them a bit later, but application of clinical guidelines, how to actually explain the Pap test, how to do the Pap test, how to troubleshoot the Pap test. So these were things that we were assessing in terms of trainee comfort in our core residents. And so in terms of actually implementing this intervention, we had to speak to a lot of the FAMED staff. So using the secretary team, using the nursing team as well, using Renaud as well, who's our IT specialist. What he helped us do was find who exactly would be eligible for this Pap test clinic. So what we did was that we took from MILE, which is the EMR we were using, of female patients aged from 21 to 65, the criteria that we used, who haven't had their Pap test in the past 3 years. And we specifically only looked at the ones who've actually had a Pap test at St. Mary's before. The reason for this was because sometimes if they were being followed by other places, it's not necessarily, it's a way for us to triage the people who've already had a Pap test and to take out those who are followed in other places. In terms of recruiting the patients, so this was a bit more difficult. We had 2 main ways to do it. The first was through the portal. And so we came up with a prompt of a message that we would send to each patient, basically explaining the creation of this Pap test clinic, the fact that it was really only for the Pap test and not for any other issues. We mentioned that if you had a Pap test before in the past 3 years to not show up, and if you were followed by someone else to not show up. And we also wrote a disclaimer that it was possible it wasn't a female resident at all times, since that was sometimes a barrier for getting their Pap test. So that was a portal message. And then we also had that same prompt that we gave to the secretary team. And they initially reached out to the green and yellow team at St. Mary's. So we initially reached out to about 209 patients, and we eventually expanded to the rest of the teams. And so that was the main way that we recruited. We'll see that the phone calls were much more useful than the portal messages. I think maybe 1 person came from the portal, but the rest were from the phone calls.
So in terms of results, the main way we assess the confidence of residents was really through a survey that we sent out pre-intervention and post-intervention. So pre-intervention, we got a total of 25 responses. And it was really, as Bao-Lam explained, allowed us to assess trainee comfort with applying the guidelines, addressing patient worries, troubleshooting for common technical challenges, explaining the PAP test procedure, and really performing the PAP test procedure. So we see that trainee confidence initially was still pretty high. The least confident was really for troubleshooting common technical challenges. In terms of post-intervention results, so we had a total of 6 PAP tests which were done. So 5 people that did the PAP test clinic actually filled out the pre-intervention survey, and all 6 filled out the post-intervention. In terms of our main result, we do see an increase in all categories when we compare pre- and post-intervention confidence survey results. The most increase in confidence is really for performing the steps of the PAP test, explaining the patient do see a mild increase in troubleshooting common technical challenges. In terms of other results that we were able to extract from our post-intervention survey, we wanted to compare the exposure of PAP tests, so how many the resident estimated that PAP tests that they did in the last 6 months as compared to how many they actually did during the clinic. In most cases, we see that the amount of PAP tests performed during the clinic were equal or more to the estimated amount of PAP tests clinic. So we do see that there is an increased exposure with our clinic. Other results that we were able to extract is that we had a possible total of 72 appointments, so 6 times 12 because it was 20-minute slots. 54 people actually showed up to the clinic, so that's an attendance rate of 75%. Out of the 54 who showed up to the clinic, 50 received their PAP test, and then we went through all the 50 that got their PAP tests. Only 40 out of the 50 needed it as per guidelines from Quebec. And out of the 54 that showed up to the clinic, 12 actually have not been seen since 2023. In terms of discussion of our results and limitations, so we do see an increase in confidence post-intervention, so post-PAP test clinic, when we compare comfort in performing the PAP test. Residents did benefit from more exposure to PAP tests as per the resident comments and the actual amount of PAP tests performed during the clinic. The clinic not only allowed us to increase trainee comfort, but also allowed us to bring back patients that were considered lost to follow-up, so the ones that haven't been seen since 2023. And based on the comments that we collected from the staff and the admin, what they really appreciated was the time slot that they allowed and the volume of patients that were seen. And in terms of things that could be improved on is just the structure of the clinic. Some patients actually showed up to the clinic wanting to discuss other issues, but I guess it wasn't clear that the expectation was really just to address the PAP test. In terms of limitations, we do have a small sample size. Only 6 people did the clinic. We don't have any comparable groups in terms of our intervention, and that really goes into our confounding factors. Is the increase in comfort just based on the natural progression of residency, where skills improve, or is it really due to the increased exposure during our PAP test clinic? There is a limited external validity as it's only a one-site PAP test clinic. And finally, there may be a certain affinity bias as the ones that completed the surveys were our co-residents.
Yeah, so overall, we think this PAP test clinic, it was a good idea in terms of exposing people to more PAP tests and increasing the confidence in residents. And I guess in terms of the conversation that we'll have today, in terms of how it can be continued in the long run, so a few considerations for that. The first is how to reduce the high number of no-shows during the PAP test clinic. Like I mentioned, the portal messages weren't too useful. And then sometimes the people who would show up wouldn't necessarily show up for the right indication. So perhaps speaking to the secretary team or making the portal message a bit clearer could be useful as well. There was also a few not contraindications, but reasons not to do the PAP test that we hadn't written in the portal message that we thought of after the patient had come, for example, if they've never been sexually active. So that was another thing to consider. And then we can look into methods in general to how to improve patient adherence to PAP test, and then how to assess the actual patient satisfaction. So I guess we'll talk about it too. We actually got the R1s of this year. So now we're all R2s. R1s of this year are actually continuing our project. And so with the new HPV screening, so that would be something that they would change, obviously. And then they're also looking at actually into the patient satisfaction. So we got some good continuation there. But we'll talk about it more today. So thank you very much.
Thanks, guys. Very good. Very good. We're going to hold questions for now. And we are going to hear next from Dr. Kimberly Munro. So I'll just ask you to keep your questions, and then we'll have sort of an open discussion at the end with questions for the groups. After we hear from Dr. Munro, who is going to talk to us about culturally targeted intervention for iron deficiency anemia. Are you ready to go, Kim?
Yep, I'm just shared. All right. So thank you for giving me the opportunity to present this project that was actually a resident project, a 2-year resident intervention on a culturally targeted dietary intervention for iron deficiency. My only disclosure is that I am the spokesperson on behalf of 2 groups of residents that completed this project over a 2-year time frame, but who have now gone off into the world to practice as family doctors. There you go. So in terms of the background, as we know, iron deficiency anemia is the most common nutritional deficiency in the world, and it affects up to 20 to 25% of the world's population, in particular women and children. It's the reasons for that are complex and are likely the interaction of demographics, socioeconomics, nutritional, and cultural factors. But the consequences can be pretty dire in terms of cognitive development in children, adverse pregnancy outcomes, decreased physical and working capacity in adults, and cognitive decline in the elderly. We also know that prevalence of iron deficiency anemia is 2 to 3 times higher in newly arrived immigrants to Canada. As many of you know, the GMFU Park Extension serves a large urban population of refugee claimants and patients who are new to Canada, and the majority of whom are of South Asian descent. So this is a common problem that we face at our clinical site. I can say that it's pretty much part of the bread and butter of our family practice. So in the first year, which is 2021 and 2022, they really defined the problem and then developed an intervention. So the team was composed of Dr. Bardwaj, Dr. Hanahai D'Souza, and Dr. Maitre Pal Singh. What they did was twofold. First, they defined the problem of iron deficiency anemia at our GMF. And then secondly, they developed a culturally targeted dietary intervention targeting South Asian women in particular, and compare that to current standard of care. So what they did initially was they started with their PICO presentation, which compared dietary interventions for iron deficiency anemia to supplements. What they found was that the literature is pretty heterogeneous. Some results showed equal effective dietary interventions as compared to supplements. So, some of them showed that they were not as efficacious. But the conclusion was that dietary interventions should be offered as a complementary approach to supplements when those are needed. They next did a MILE, so our MILE is our EMR. They did a data collection to estimate the prevalence of iron deficiency anemia at ParkX, and they found in women of childbearing age it was about 21%. The third part of their project was to develop a culturally targeted dietary intervention, and this was a big piece of work. And they worked with our nutritionists here at ParkX, who are also quite specialized in dealing with iron deficiency anemia. And they developed a handout and translated it into 5 different languages, so English, French, Punjabi, Urdu, and Hindi, which are the main languages that we do see here in Park Extension. They handed out the handout to 52 patients, mainly women and children, and 50% of those handouts were in South Asian languages. Among the women who received the handout, 53% had iron deficiency anemia, and over half were also treated with iron PO. So going back to their PICO, it seemed consistent with the recommendations coming out of their PICO. So as a reminder, this project did win the PBRN prize. Here is this the dietary intervention. So there are the examples in both Hindi and Urdu. I'll show you in English and French as well. So what they did is, so it's a two-sided form and in color, which I think is helpful, of South Asian foods that are rich in iron. So they include mainly vegetarian foods, but also, as you can see, some non-veg options as well. And then on the back side of the form, they gave examples of different types of snacks and meals that could be tested out. Again, this was done in collaboration with our nutritionist. The following year, another group of residents decided to take on the project and carry it forward. And they wanted to look specifically at the use and appreciation of this tool that the patients received. So this team was composed of Dr. Alicia Shako, Dr. Thuyan Maivo, and Dr. Kim An Tran. Their goal was to determine the use, appreciation, and effectiveness of this dietary handout, to promote also as a secondary goal to promote the primary care provider's cultural competency and to empower patients in terms of dietary choices, and integrate our clinic's core values and commitment to diversity, inclusivity, and compassion in order to provide quality care to our patient population. They developed a questionnaire, and then they conducted semi-structured interviews with patients who had received the handout. And this is really important because with the use of the PBRN prize money, they were able to pay a research assistant who was able to take time to conduct the interviews in the language of the patient's choice. So in terms of interviews conducted, they were able to reach 6 patients who all found the handout useful and thought it should be continued to be shared with patients with iron deficiency. Here's their questionnaire. So it was a 10-point questionnaire using a Likert scale for answers. They also obtained some qualitative feedback from the patients. So you can see here that most of the patients really did find it useful and helped them make dietary choices and appreciated the fact that it was it was adapted to the language that they can understand, but also culturally adapted foods were presented on the handout. So these are the lessons that we learned at our site. Dr. McLaren and I have been co-leads for the scholarly project for a number of years, and this is the first time that a resident project was continued for a second year. So we were thrilled with that. I will say that the first year project, that's the year that they really had to lay the groundwork and do the mild data search and also ensure that the project was relevant to the context. So I think that was a lesson that we carried forward now at our site, and we tried to include our residents more in our QI committee so that from the outset they're able to define subjects that are useful to the clinical context, because sometimes coming into R1 you're not really quite sure what is clinically relevant. The second cohort, though, they were able to really bring a new energy to the project. So they took it forward and they were able to develop this idea of reaching out to the patients, which was also a first at our site. And as staff, Dr. McLaren and I were able to provide some guidance and continuity in terms of the two projects going forward, because while the two groups did meet, because there was a little bit of overlap, because of timing of residency and everything, it was hard to schedule meetings for them to continue to work together. The PBRN funding was very helpful because it did allow for the hiring of a research assistant, and in terms of residents and how much time they have to commit to their QI projects, it was really helpful to them to not have to be the ones to try to reach the patients and then to conduct the interviews. So they were very appreciative of that. And then in terms of the patient perspective, as I said, it was the first time at ParkX that we sought patient perspective on a QI project. And while it was essential and interesting, it did add to the complexity of the project because you do need to go through an ethical consideration. And in terms of the timeline of the scholarly projects, sometimes this cuts the time short. So for instance, they only had six people that they were able to reach, but they did appropriately go through the process of obtaining consent from those patients. So in conclusion, this is a tool that's really useful for our clinical setting and continues to be used today. So it has been integrated into our obstetrics folders that all new patients to our FMOB clinic receive, and providers like myself continue to use it on a daily basis to hand out to our patients. Thank you. So I'm open to any questions.
Thanks, Kim. I think that's excellent. And I think it really illustrates the benefit of being able to carry these projects, over from year to year and see them advance. I'll maybe just ask a quick question. Antoine et al., do you guys know if anybody's interested in carrying your project forward this year?
Yeah, so the R1s this year actually carried on the project, but with the new HPV test, and also looking at patient satisfaction to bring new outcomes.
Wonderful. Great. Does anybody have some questions for either Kim or for Antoine and colleagues?
I do.
Did I hear something? Or...
Yeah, I do. I have a question, Tom.
Yes. Oh, hi, Michelle. Sorry.
Okay. So just a general question. So what I'm understanding is that the limitation or the challenge in making sure these things continue forward is the interest of the next crop of residents who are part of that clinic. I guess my just general question is, at what point can the results of a project be deemed to be a success such that it is integrated regularly as part of the clinic procedures? Like, for example, you did the PAP screening as part of those sessions in February to May. Could those not just be included next year? Or does it need people to run it specifically, like without having the three of you there, it just can't work. You need to have people to take over.
So initially, like, we had positive outcomes, but I think the amount of residents that actually had the exposure wasn't enough for us to continue. That's why we wanted the R1s to kind of continue the project and really see if patient-wise there is an improvement. In terms of implementation-wise of the PAP test clinic in the procedures month, initially it was a bit of a battle with admin too, because we had to set everything up and find proper supervisors, which in the end we did find. All of our supervisors, I think we had about like 6 or 7 of them, were all had an incline in obstetrics or gynecology. So in terms of supervisors, we do have enough, but admin-wise, I think it was more to continue the project. It was more on the admin level to kind of find the proper resources for that.
Yeah, and for our clinic specifically, so in terms of timing, like, it was difficult too, since a lot of us were either going into rural as going into R2, or I was gone from St. Mary's for like 6 months straight. Then, so in terms of our presence here, or the lack thereof, it's more difficult to continue pushing. And on top of that, there was a lot of administrative and other logistical issues with the clinic that we didn't necessarily talk about in our presentation, but things like we were lacking material in the rooms. We were lacking, for example, speculums were running out, like there's no tomorrow. So in terms of monitoring those logistics and then pursuing it, that was another thing that we talked about with the R1s in terms of like preparing the clinic a bit better. So I think it was a combination of all of that that sort of made it a bit more difficult to continue. But we spoke a lot with the incoming R1s in terms of the shortcomings of our initial project and the ways to move forward. So hopefully it'll continue.
And I think also the staff at St. Mary's didn't necessarily want the PAP test clinic to be a way for every resident to just send their patients to the PAP test clinic and not have to do the PAP test themselves for your patients. So that was also a sort of reticence from the staff at St. Mary's too.
Laura.
Yes, I was just wondering because, one of the objectives, say, of this talk was to talk about how to build on previous QI projects to share them across space and time. So what did you guys do successfully at St. Mary's to recruit the next batch? Was there a specific mechanism, or it happened more naturally?
I think it was more natural. I think it was more natural. We were as the QI starts getting introduced to the R1s, we just kind of spoke about our project. We also presented during grand rounds, which was very helpful. So they kind of knew about our project too. And then some of them were looking for ideas, so we kind of just talked about our project and then were interested. So there wasn't a clear mechanism or clear strategy. We just kind of talked about it and someone picked it up. So.
Yeah, and I think this is sort of one of the challenges that a lot of the times residents face is that you really need a champion who has a bit of influence in the clinic to support some of these projects moving forward. So I think that probably highlights a bit, Kim, like your ability to move this project forward because you and Laura are there supporting it and and that is really crucial, I think. Elaine.
Oh, this has been great. Kim, I have some ideas and questions for your project on anemia. So it's sort of interesting that, this, guidance, dietary guidance has been, obviously helpful. Patients of South Asian origin seem to appreciate it, which is great. But we all know that knowledge doesn't equal behavior change. And there are all sorts of impediments to the application of knowledge into practice that we need to know about, right? And because patients, lives are complex, and and there are all sorts of, competing kind of issues occurring, which make it very difficult to implement knowledge and make that behavior change. So I think it'd be interesting, for students to perhaps appreciate some of those things through a next phase, which perhaps looks at some of the challenges around application of the guidelines. And that would, I think, create some sensitivity to them of those complexities, which are really important for them to apprehend. And the other thing is more of a research project, but wouldn't it be interesting also to see, to what extent this actually makes a difference in terms of improved kind of rates of or sorry, decreased rates of anemia in the population that's sort of receiving this guidance and applying it. So I think those are two suggestions for continuing. It's so important. And anemia is such a big issue in South Asian population. It's really important to address it as you have. But, just moving it a bit further might be quite an interesting thing to do as a next step.
Yeah, there is a couple of things that maybe that I didn't include in the presentation. One one is actually that there's actually several iron deficiency projects that have been done in Park X, including one that was led by Dr. Patricia Lee, who is a pediatrician who does community pediatrics at the clinic here, in collaboration with the nutritionist. So this actually even nicely inscribed itself within that bigger research project that I think was also PBRN funded, or Réseau, if I'm not mistaken. And so this was more of a QI project on the same topic. They did hope to look at the ferritin, and I think they tried to look at the ferritin in terms of the second year, but the issue with the patient consent came in because they would have liked to look at the data wasn't collected for all of the 50 handouts I think that were given in terms of the patient numbers, the patient file numbers. So they kind of they didn't have a lot of data on whether or not this actually affected the ferritin, but that was one of their hopes when they initially designed the project, and it became not possible to do. So I think you're right in terms of going forward to seeing if it's useful, because as obviously as providers, it made us feel better to hand out this really pretty 2-page handout, but that was why the second year project was important to seek the patient feedback on it. Did they like the handout? Was it useful to them? And like you said, the next phase could look at whether it actually is clinically significant.
And I would have to just add to that is for behavior change, one of my favorite qualitative feedbacks from that project, I don't think you had it, Kim, was a couple people said they put it up on their fridge.
Yeah, that's true. Yeah. And I think that's where family medicine comes in as well, right? Because it's a tool that has been adopted in the clinic and becomes a speaking point at visits, right? So each visit you tend to review the dietary the dietary habits and also whether or not they're taking their supplements. And so it's a way for us in clinic to continuously follow up on their behavior.
And so I think again on the theme of maybe because I know when we introduced this project in different ways, there was other sites that were interested in maybe having this handout and doing something else with it, and I don't think that ever happened. So what was the impediment to that? Because I think it could have been very well used at other sites, but it never has been.
Mm-hmm. Yeah, I'm not really sure how to answer that, Laura, but I think that's and this is sort of comes back to this idea of how do we share knowledge effectively between the sites, and we've talked about, having a database and things like that, but I mean, these things are logistically difficult to manage, but definitely usable stuff across many places. Dr. Dove has her hand up.
Yes. Thanks for both of these presentations. Very interesting, both of them. I wanted to address the issue of the use at other sites. I would love to have that anemia explanation sheet here at Côte des Neiges, and I would find it very helpful. I understand Elena's point about we don't know what actually changes behavior, but so much of what we're doing in family medicine, we have no idea if it's changing behavior. Like I'm giving people Canada's food guide, but I'm not sure if that's changing behavior. So I would love to have some culturally adapted tool to give people. And how to get that to happen. I mean, it's really, I think I hear you about the database, but I'm not going to go look in a database. I just am not going to do that. But word of mouth, like people who are using it could share it within their I don't know, the family medicine OB group or something like that. Like I'm really thinking that like sharing it with people, presentations and things like that is the way to go rather than online databases.
Oh, I agree. That's why we haven't really pushed too hard to finish that off ever. Antoine, question for you guys. Sorry, I keep picking on you, Antoine, because that's the name I see on the screen. But have you guys thought, because there's a lot of people out there who don't have family doctors, have you guys thought about opening up a screening pap test clinic for people not registered at St. Mary's to try to, maybe get some buy-in so that, you're not just transferring all your patients to this special clinic, but you're actually bringing in people who maybe don't have care already?
Yeah, so we definitely thought about it. There was I think the Jewish at the Herzl, they did something quite similar last year. I think it's more of a logistics question because St. Mary's doesn't accept patients that are not registered underneath St. Mary's. And so all of our patients were already underneath resident practice. Those are people we focused on. And we spoke about it with the staff, with admin, and we decided to go more for the patients from St. Mary's. But it's definitely a very good idea. And I think we inspired ourselves a bit from what the Jewish had done as well. So, yeah.
Dr. Munro.
Yeah, I have a question for your group as well. Because we also had tried to do pap test clinics here for resident exposure and in terms of access as well. And I'm wondering about the point that you made in your presentation about the timing during residency of having residents do those clinics. Because we did find that maybe the R2s were less enthusiastic, and I wonder if it was a timing issue because they felt they had attained that skill. And would you recommend, based on the feedback that you received, having residents participate in it during our 1 year?
So it's a very good question. I don't have the actual data in terms of like separating the R1s and the R2s and figuring out whether they found that it was, more positive or negative. From what I remember though, like going through all the comments, it seems like the R2s were very enthusiastic about having that as well. Um, in my personal experience, and maybe you guys can share too, in terms of the pap test exposure, the main times would be either during the FAMmed clinics or the OB month, where you're doing a lot of these sort of exams and a lot of these like speculum exams. And so those were the ones that are the most useful for me. It's possible that that was, really focused for some R2s, at the beginning of the year, whereas when they were R1s, as opposed to, for example, Antoine, who's never had a procedures month yet, and he's middle of R2. And so I think it's very variable. From what we've heard, though, that it seems like everyone was enthusiastic, but it's a good question.
And also based on the question that we asked the residents in terms of the estimated amount of pap tests that they did and how much they actually did during the pap tests, we do see there is an like pretty good exposure compared to what they did in the past. So I think with that data, maybe you can kind of infer that it was useful and they were pretty enthusiastic.
Yeah, I think these like, condensed exposures where you're doing, one thing repeatedly, it helps consolidate knowledge and skills. So does anybody have any other thoughts or comments? Michelle.
Sorry, going back to the residents. So if the three of you had a chance to continue this project, what would you do differently, or how would you expand it?
In terms of like the future, I guess the future considerations of how to pursue this clinic, how to make it better, we kind of discussed with the R1s as well. So one main thing was the patient satisfaction if they found that it was a good experience. So that was an interesting direction that we could take. In terms of more logistical, a lot of the times it would be to make sure that when they're doing the pap test that there's enough sort of material in the room. So that was another barrier. Those are the two off the top of my head. Now that we have the HPV test that's coming, it'd be interesting to see whether, I think it's 5 years instead of 3. So it could reduce the number of patients, waiting for the pap test as well. So that's something that we could measure as well. I think those are some interesting directions. We kind of talked about it at the end of our presentation.
So I find it interesting that it's really nice. It's too bad Sonia Lucier was here for most of the presentation, and she's a patient partner representative. So she'd be happy to hear that that was where you guys wanted to go. And then, but in these QI projects, so much after an intervention is sort of established, the next step is to see how it's working with the patients. But the thing to really try to clarify, which isn't clear at all still to me after all these years, is the ethics and how to make that more streamlined and able to do, because it's such an important aspect of our QI project.
Yeah, I think that's a difficult point, and I struggle with it because if you're trying to get feedback from patients on how you're running the clinic, having to go through a huge, arduous ethics process for just a bit of feedback seems like you're never, at the end of the day, what's going to happen is clinics are just never going to get feedback from patients. That's the reality. So I find it unfortunate that seems to be currently the way things are going, and yet you can do, QI. I don't know what they do at Park X, but the CEUS does their patient satisfaction surveys and stuff like that. And one way of maybe, sort of streamlining it is to get involved with the CEUS group and just add a couple of questions in there that we want answered. Because often those questions are not necessarily relevant to what we actually care about. They're often directed at accreditation or something which is not necessarily so relevant for our day-to-day practice most of the time. All right.
Any more questions or comments or no? Okay, well, thank you everybody for being here. Thank you especially to our speakers, to the three residents, and to Kim and Munro for really interesting talks on these great projects. And as PBRN co-chair with Dr. Laura McLaren, we would love to help support you guys in carrying things forward in any way we can. So please reach out to us if you have ideas or if you feel stuck somewhere. Maybe we can help. Oh, and know that we are probably going to be launching a project competition in the new year. So that could be an opportunity to expand your project in different ways. So thanks everyone, and thanks Keith for moderating, and see you all at the next PBRN seminar.
Thanks,
Thanks everybody.
Bye.
Bye.